very good evening to every one of you who's logged in today for this interesting session about stroke that Click2Clinic is hosting. I'm Dr. Shravani Reddy. I'll be your moderator for this evening. We've got our set of panelists and speakers joined us today. We've got Dr. Sujit Reddy joining us from USA, the founder of Click2Clinic Inc. We've got Dr. Anil and Dr. Bharat, our expert neurologists, to join the panel today from the United States again. Warm welcome to all of you.
Thank you.
Thank you so much for joining us. And Sujit, over to you.
Thank you, Shravani. Hi, guys. Welcome to the Click2Clinic Care Sessions. For the topic today is the stroke prevention, treatment, and recovery. And this is on the occasion of October 29th being the World Stroke Day. Click2Clinic Home Health is India's leading health tech aggregator with more than 40,000 providers empaneled with us in 6 major metropolitan cities. And on behalf of Click2Clinic, I am joined by our Chief Strategy Officer and the moderator for the session today, Dr. Shravani Reddy. And according to the World Stroke Organization, every year around 15 million people have stroke, out of which 5 million people die from it. And around 80 million people are living with the aftermath of the stroke any given day. So it's a huge public health burden. And as you know, the disease is deadly and debilitating. And we have our panelists today who are experts in the neurology field. Dr. Anil Nilakanthan is an adult board certified neurologist with impeccable credentials. And we are also joined today by Dr. Bharat Naravetla, who is an interventional neurologist and a stroke neurologist. So that will cover our prevention, treatment, and recovery aspects. So with that, I welcome you all. And this is a free-flowing interactive discussion, but after the brief slides are presented by the panelists today. So thank you all for joining again. Look forward to a great session today.
Thank you so much, Sujit. Before I hand it over to Anil, we'd like to keep this as conversational as possible today. We'd like to prove that clinical discussions are definitely boring. So let's make this interesting. Like we've been posting, we're talking about debunking some really popular myths about stroke. We will do that as we go along. So Dr. Anil, over to you. We will start with probably addressing the basic and most popular myth probably. Does stroke happen in our hearts? Can we begin there?
No, so stroke is basically a condition where there's actually an interruption of blood flow to the brain. So it can be either a blood clot that blocks off a certain blood vessel, causing cell death in the brain, or where the cell can be transiently stunned because of the lack of blood flow for a short period. The second type of stroke is where a blood vessel ruptures and that causes bleeding into the brain. So the first one is called an ischemic stroke, and the second one is called a hemorrhagic stroke. There are certain strokes that where the blood clots come from the heart and affect the brain, but a vast majority of strokes are actually caused by a blood clot from the blood vessels that lead up to the brain rather than coming from the heart. So it is not true that all strokes start in the heart. So 87% of all the strokes that occur are because of blood clots, while 13% of all the strokes occur because of a rupture of blood vessels or bleeding. And as Dr. Poonam said, it affects about 15 million people every year. That's not a small number, as you know. And out of these, 1/3 die. 5 million die each year, and 5 million are permanently disabled. If you look at the incidence in India, the incidence has gone up twice, 100%, from when compared to the 1970s to now. And it occurs, there's a difference between the rural areas and urban/suburban areas. In rural areas, it occurs at 262 per 100,000 population, while in urban, it is 424 per 100,000 population. And in India also, it occurs at a younger age, 15 years younger on an average when compared to developed nations. And about 20% of the strokes are actually below the age of 40, which is stunning. Because typically we think of stroke as something that affects 60 plus. Can we go to the next slide, please? So what are the things that would put someone at risk for having a stroke? High blood pressure is one of the biggest ones. Diabetes, an irregular heartbeat known as atrial fibrillation, cholesterol, high triglycerides, smoking, sedentary lifestyle, sleep apnea, which is where you, for the most part, you snore, and that can cause low oxygen levels during the nighttime, kidney disease, and heavy alcohol use. These are the modifiable risk factors, meaning these are the risk factors where you can do something to either mitigate or reduce the effect of it, or sometimes even reverse it. There are certain non-modifiable risk factors, which you can't do much about, which is family history, genetic conditions and mutations, and age. So these are things that we really don't have much control over, and gender.
Allow me to pose a question here, Anil. The second myth that, like you rightly mentioned, is wherein people think that it is for the elderly, that stroke could not happen to a younger adult. And now, like you rightly presented the stats there, we see there's a rise in, strokes in young adults as well. Now, for a 30-year-old or a 40-year-old, how does age and gender doesn't matter? And what, as for the list of the risk factors we just discussed, what could be the top 3-4 issues for this?
So in other words, what is the most common cause of strokes occurring in younger people?
Yeah, maybe top 2 or 3 if we could list it out. Tell me why I could have a stroke.
Yeah, so so strokes in the young have oftentimes a different set of problems that actually might trigger it. Now, granted, even though strokes in the young are a unique subset of strokes, vast majority of the strokes in the young actually occurs in people who have other cardiovascular risk factors like hypertension, diabetes, cholesterol, because those are occurring in younger and younger people as time goes on. However, there's an additional set of conditions that can cause strokes in the young too. There are certain genetic mutations, there are certain autoimmune conditions where your immune system creates certain antibodies that can increase risk of developing blood clots. For example, antiphospholipid antibody syndrome. There's also conditions like what's called factor V Leiden mutation, prothrombin mutation. These are genetic conditions that increases the risk of developing blood clots. And those blood clots can then cause a stroke. And one of the other risk factors in younger population is a hole in the heart. And it's called a PFO, patent foramen ovale, which basically is a tiny hole in the heart that about 1 in 4 people have. But in some people, the hole may be a little bit larger. And also there can be a lot of flow that occurs from the right side of the heart to the left side of the heart. In addition to that, there can also be a very flexible septum that divides the left upper chamber of the heart from the right upper chamber of the heart, and that can increase the risk of having blood clots also. It's called an atrial septal aneurysm. So there are certain unique set of conditions that can predispose or make it more likely for someone who is younger to get a stroke. But given that, still, the vast majority of strokes in young people occur because of the general cardiovascular risk factors, mainly emanating from lifestyle and hypertension, diabetes, which is occurring in younger and younger people now.
If we have to break it down further, Anil, we look at World Stroke Organization's campaign this year, talking about join the movement, be on the move and be more active, and probably, not having enough physical activity included in life is supposedly one of the risks. And if one of us on the panel, any one of you could comment on how digital toxification because of COVID and the kind of sedentary lifestyles it has forced all of us to get into, especially in the younger generation, and I'm even including kids and teenagers. Can one of us comment on that? Is that a risk factor enough?
Absolutely, it is a risk factor. So the AHA and ASA, which is American Heart Association, American Stroke Association, recommend moderate to intense physical activity, 30 minutes a day on 3 to 4 days at least per week in order to maintain a healthy lifestyle. This has several benefits. One, it gets your heart healthy. It reduces the chance of diabetes and hypertension. Those lifestyle diseases can improve, and it goes beyond that. So, being a neurologist, we see dementia all the time. And one of the most effective interventions to prevent dementia or reduce the chance of developing dementia is actually exercise. If only exercise could be packaged as a pill, people would take it. So because it's that effective, it's more than anything, it's more effective than any other intervention for preventing dementia. So now, is more exercise better? Probably, but the data that we have right now is at least 30 minutes a day, 4 days a week minimum.
Yeah.
And what level of intensity of exercise do you need? Well, it's moderate to high intensity. So there's something called a target heart rate. So target heart rate depends on your age. So there's 100% target heart rate, which is the absolute maximum you can go to, or you should go to. Typically, if you plug in your age, you can get the calculation of what that 100% is, and you should target for maintaining a 50 to 60% of that heart rate for about 30 minutes continuously each time you exercise, and do that 3 to 4 times a week or 4 times a week, and that would be the minimum that is expected to reduce your risk factor of developing a stroke. Now, in COVID times, this presents a unique challenge for several reasons. Number one, people are having work from home. A good number of the young generation is, for lack of a better term, hooked onto their phones, tablets, computers, iPads, whatnot. And so they have less impetus to move. You have meetings all day. You're sitting in your chair, not moving much. And so, and in addition to that, your opportunity to go outside is quite limited because you have to maintain social distancing. So you can't really walk outside too much unless you are in a scenario where you can maintain that 6 feet distance. So it becomes all the more important to plan ahead and do your physical activity in such a way that it would not interfere with your work or with your safety from a public safety standpoint. So it does pose unique challenges.
Yeah, Dr. Anil, if I may interject here, this year's theme, I think, is very appropriate for a country like India, don't you think? Because if you look at it, the strokes are happening at a much younger age. Mm-hmm. And the stroke in the young, like you just mentioned about patent foramen valve, things like that, they might not be the whole factor. The biggest factor probably is, inactivity, change lifestyles, change eating habits, and faster pace of life. I think it's taking a toll, don't you think? Because people who are supposed to have strokes from the diabetes, high blood pressure in the 50 years and 60 years and 70 years, they're having strokes at 30 years, 40 years, and 50 years.
Absolutely. Absolutely. I 100% agree with that. It is a large majority of strokes in young are because of lifestyle and lifestyle related diseases rather than because of the genetic conditions or the PFO that might be causing the stroke.
Great.
So going forward, looking at hypertension. So one of the risk factors is hypertension that we spoke about. This is by far the single most important risk factor for stroke. The goal should be to try to reduce the blood pressure below 130/80. Now, there's a debate as to exactly what that target should be. The reason being, when you bring it below 140/85, it has shown to significantly reduce the incidence of having blood clot related strokes. However, when you bring it much below 130, it has been shown to not only reduce blood clot related strokes, but also hemorrhage related strokes. But the blood clot related strokes did not decrease any further. So because there is a decrease in hemorrhagic strokes as well, the current recommendation is to keep the blood pressure below 130/80 to prevent both types of strokes, even though there was no difference in the blood clot strokes between 130 and 140 and 80 to 85. And there's a unique exception to this, diabetics. In diabetics, reducing the blood pressure below 120/80 can reduce the strokes risk even further by an additional 41%. The other risk factors, obviously, is diabetes. When someone's diabetic for more than 3 years, they have a 74% increased risk of stroke. So the goal to bring the blood sugar down should be to bring a hemoglobin A1C. Hemoglobin A1C is a measure of how well your blood sugar was controlled for the previous 3 months or 120 days, which is one cycle of the red blood cells in your body. So when you have a glucose spike, the glucose attaches itself to the hemoglobin molecule inside the red cells. And since those red cells are recycled only once every 3 months, if you look at how much hemoglobin has glucose attached to it, you can tell how well your glucose was controlled for the previous 120 days. And that percentage of hemoglobin onto which glucose is attached, otherwise known as hemoglobin A1C, sometimes called glycosylated hemoglobin, should be less than 7. Some people target even more strict 6.5, but the problem with that is you run the risk of developing low blood sugar when you do that. So the goal that AHA-ASA recommends, American Heart Association, American Stroke Association recommends at this time is to bring the hemoglobin A1C less than 7. Atrial fibrillation, irregular heartbeat, is another risk factor for developing stroke. So as you know, the heart has upper chambers and lower chambers. The upper chambers contract first, and then lower chambers contract, pumping the blood out into the system. In atrial fibrillation, the upper chambers are not effectively contracting because it's beating too fast, and the upper chambers are just vibrating without having an effective contraction. This can cause blood clot to form in a certain part of the upper chamber, in a certain nook of the upper chamber called the left atrial appendage. And every once in a while, that can get dislodged from there and go into the lower chambers. When it gets into the lower chambers, it can get pumped out into any of the organs in your body, but the straightest path from the heart is the head. So oftentimes it causes a stroke more than anything else. Now, cholesterol, this has a very complicated relationship because there's different parameters that would determine whether cholesterol is a problem or not, depending on whether you have had a stroke or not, depending on whether you have a high risk of developing a cardiovascular problem in 10 years from now, something called the Framingham score risk. So it is a very complex relationship. We can get into that if we need to down the line, because if I spend time on that, we can talk 1 hour about this. Smoking. Smoking increases the risk of stroke by 400%, 4 times. So this is something that is an absolute no-no. It is best to avoid smoke, first-hand smoke. Second-hand smoke also increases the risk by about 25%. As we spoke about exercise, 30 minutes a day, 5 days a week. This is 5 days a week. This is from the dementia perspective. 4 days a week is American Heart Association perspective. So I tend to take the bigger one, because if you can kill 2 birds with 1 stone and prevent dementia and prevent strokes, that's better. And so 30 minutes a day, 5 days a week, or 150 minutes a week with a target heart rate of 50 to 60%, which we spoke about a few minutes ago. Kidney disease, this is a big one. This increases the risk of stroke anywhere from 5 times to 30 times, especially in those who are on dialysis. Now, there's a strong association between sleep apnea and stroke, and all of us know somebody who snores bad. So snoring is and sleep, not all snoring is sleep apnea, but snoring is very likely to be associated with sleep apnea. And sleep apnea can trigger strokes or increase the risk of strokes. And the association is pretty strong between the two of these, that the stroke prevention guidelines now state that pretty much everybody who has had a TIA or a stroke needs to be screened for sleep apnea, either using a bedside screening questionnaire called an Epworth Sleepiness Score, or if there's a stronger suspicion, they have to be sent for a polysomnogram or a sleep study, which can be done to determine if they have sleep apnea or not, and it needs to be treated. So if you are seeing somebody who snores, tell them, hey, got to check it out because it increases risk of stroke. And by the way, we spoke about dementia, it increases risk of dementia also. Now, DASH diet and Mediterranean diet. Diet plays a huge role. High sodium diet, high fat diet, more so sodium than fat. High sodium diet is actually pretty well known to increase risk of cardiovascular risk factors. Now, there is this DASH diet that has been shown to reduce hypertension, which has also been shown to be effective for cardiovascular health. Mediterranean diet is also equally effective. So now, from a neurological perspective, in many cases, what they're doing is they're asking to combine the two diets, and it's called a MIND diet, M-I-N-D, MIND diet, which is a combination of DASH diet and Mediterranean type diet. Reduces risk of strokes, and again, reduces risk of dementia.
Yeah, it's interesting you mentioned diets as well, Anil. One of the latest fads, at least it's been for the last 3-4 years here, has been keto, which is huge, which is high on fats. Any comment on that?
So keto diet, yes, it puts your, so the idea there is to basically minimize the carbohydrate intake, which puts your body into a starvation mode, that then causes your body to utilize the adipose tissue in your system and the fat tissue in your system to take it out and convert it over into energy source that your body can utilize. Now, but you need to get your daily calories somehow, so you'll have to either get that from a little bit of protein and fat. Now, many a times the keto diets, in addition to protein, tend to be relatively high in fat. Now, the dietary relationship between your serum cholesterol, vascular risk factor, and dietary cholesterol is an extremely complicated relationship. The reason being, the vast majority of cholesterol that is created in your body is actually created by your liver. Extraneous cholesterol that comes in, the impact of that on your LDL cholesterol, it's certainly there. It should not be discounted, but it is not a direct one-to-one correlation. Now, triglycerides, on the other hand, is something that comes in directly from your diet and gets directly absorbed. So it is not as straightforward, oh, you're eating an extremely high-fat diet, so it is gonna increase your risk by 10,000%. It's not a direct correlation like that, but because triglycerides is an important part of the fatty diet, number one, and because cholesterol has been known to be an increased risk factor, especially for those who have already had a cardiovascular event or already are at a higher risk for a cardiovascular event, it is certainly something that you should be extremely cautious about and be mindful of. And that ties back into this diet of DASH diet and Mediterranean diet that is known to be richer in unsaturated fats or polyunsaturated fats, legumes, vegetables, fish, a little bit of white meat, very minimal to none red meat, and that's the kind of, and which is low in sodium and high in potassium. That's the kind of diet that they're talking about with the DASH diet and Mediterranean diet. So when you talk about a keto diet, it might break many of those principles.
Right.
And for the Shravani, for that question, if I may chip in,
Yes.
the verdict is not out. We do not know. Now, when Dr. Anil mentions DASH diet and Mediterranean diet, they have been tested, they have been proven. That's why they got into the guideline. Whereas the keto diet is something not been tested. So we do not know. We cannot make a clear comment on that.
Sure. I hope the slides are visible to all of us.
Yes.
Yes. So secondary stroke prevention, what does that mean? It means preventing another stroke in somebody who has had a stroke or a mini stroke, otherwise known as TIA, which stands for transient ischemic attack, which is a stroke that came and went without leaving any permanent damage. So this has to be treated slightly differently than someone who never had a stroke. So you give blood thinners, which would be aspirin, clopidogrel, and aspirin diprodamol are the three mainstays that we would use. Mostly, the biggest evidence is for aspirin. In certain select conditions, we would use stronger blood thinners, warfarin or direct thrombin inhibitors. And then as we spoke about all the aggressive risk factor modification that we need to be really on it. And sometimes there's also a question of, can you combine two kinds of blood thinners? Under certain circumstances, it needs to be done. And there are certain very specific guidelines, which if anybody has any questions about that, we can talk about that. And there's also the new devices that are available that have been approved for closing that hole in the heart. Again, not everybody's a candidate for it. There are certain select people who might be a candidate for closing the PFO.
Okay.
And then, of course, there's the other secondary stroke prevention, which is a clogged up blood vessel, which needs to be cleaned out, which can include surgery to clean it out by opening it up, or stenting, which Bharat is going to tell us all about, because that's what he does every day.
Thank you so much, Dr. Anil. I'll come back to you with some more questions once we're done discussing the acute care of stroke. We have Dr. Bharat Naravetla who's going to take that discussion forward. Over to you, Dr.
Thank you, Shravani, and thanks, Anil, for setting up the stage with a nice overview of the stroke. So, the one point I want to convey to everybody on this topic is time equals brain. I will talk about it towards the end of my presentation, why time equals brain. So these are the disclaimers. You can pass it. So we know that strokes are two types. First type is the ischemic stroke, or the blood clot coming and blocking the blood vessel, which is 87%. And the other type is the hemorrhagic stroke, meaning the bleeding into the brain, which is a disruption of the blood flow by rupture of the blood vessel or by rupture of abnormalities of involving the blood vessel, which is like an aneurysm or AVM. We'll talk about these. The main one is the ischemic stroke. So as we see, the clot is occluding the blood vessel and causing the area of the brain which is supplied by that blood vessel lack of blood flow, and like eventually leading to the death of that tissue, damage and permanent death. So we know that right side of the brain controls the left side controls the right side. So if the left brain is affected, that's where the speech center is also. So people will have a difficulty speaking and then have the difficulty controlling the right side. Whereas the right side, it is opposite. The left side of the body is paralyzed, left side of the vision is gone, and you may have a slurring of the speech, meaning the dysarthria. This is the right and left side, but there is another important part of the brain, which is like a brain stem, which lies in the back of the brain, which is nothing but a conduit or a pipe where the in and out connections of the brain to the body are going through. That is called the brain stem. When the stroke happens in this area, which is like really a devastating stroke, and the abnormalities or the symptoms depend on what are the different structures in the brainstem involved. So these people can have a abnormal eye movement, double vision, or blurring of a vision. People may be unconscious. People may have a dizziness. It can present like various things. So one of the important structures or important stroke people need to pay attention to. So previously we used to say acronym as a FAST, F-A-S-T, for recognizing the stroke on the field. Like when someone is having symptoms, you use the acronym FAST, but that is being modified to B FAST. So B stands for, trouble with the balance. If someone is not able to stand and having like a falls or stuff like that. E stands for difficulty with the vision, any double vision or the loss of vision or a blurring of the vision. F stands for face. When someone has a facial droop, one side of the face is like paralyzed. A stands for arms. When someone cannot hold their arms like for 10 seconds, that's one of the signs. S stands for speech. So when someone has a difficulty speaking, meaning like not able to talk to you, not able to answer questions, or if someone has a significant slurring of the speech, these are the symptoms. When you find be fast, then the time. So the time is you act immediately. The reason for that, as I was saying, time equals brain. It is estimated that 1.2 to 1.9 million neurons, meaning the brain cells, which is like a 12 lakhs to 19 lakhs of the brain cells are dying every minute. Every minute, 12 to 19 lakh neurons, the brain cells, are at risk of dying when the stroke happens. So the key is to re-establish the flow as quickly as possible. Sooner you re-establish the flow, the better the outcome. So what do we do to re-establish the flow? We are talking about the ischemic stroke, which is like a blood clot obstructing the blood vessel. So, you can use a medication IV through the IV, which is called the IV thrombolytics, also called alteplase, also called the TPA. But the problem with this is it's a very powerful blood clot buster. We call it a clot buster, and it should be given within 3 hours. In the selected cases, within the 4.5 hours from last known normal, meaning you need to know when the patient was actually normal, like didn't have any symptoms, and start your time. And you can only give within 4.5 hours from that time period. Sooner you give, better it is, because every minute up to 19 lakh brain cells are at risk of dying. So this medication, as we know, there is no medication which is 100%. So this medication also, even though it is a very powerful clot busting medication, it can only work in 1/3 of the cases. So remaining 2/3, it is unable to dissolve the clot, or people may present after 4.5 hours. So in that case, you cannot give this medication, or people may have a contraindication. Like someone may be having a bleeding, the GI bleeding, like a bleeding into the stomach, a bleeding ulcer in the stomach, or may have had a major surgery, like a heart surgery or a GI surgery, any kind of a major surgery within last 2 weeks, you can't give this medication. So there are limitations with this medication. And also, since this medication is very powerful, it can cause bleeding into the brain because the brain is getting damaged. We all know if you cut off the blood supply to the brain, what is happening is, the brain dies within 5 to 10 minutes. We all know that. But we are talking about like hours in here. How is this possible? This is possible based on the next slide, which we are going to show. So what we are seeing is right in the center, when the blood vessel is coming up and it is supplying, the God has created the brain with multiple blood vessels overlapping the blood flow. So when this central blood vessel is blocked, the area which is supplied by the core is dead within 5 to 10 minutes. But the surrounding area is not getting enough blood flow, and it is still alive because the blood vessels which are next to it are still able to supply a little bit. But this is the area which is at risk of dying. We call it penumbra, meaning the tissue at risk. This, if you don't do anything, the area which is a lighter blue and even lighter blue is going to die or is at risk of dying. This is where we can make a difference. This is where giving clot busting medication, trying to reopen the blood vessel, will reestablish the flow. But what happens is the right in the center, where that black tissue, the core is, that tissue can leak the blood. When you give the strong clot buster, it's more likely to bleed. So there is a 3% risk of dying from that bleed, 33% doing better, but 3% risk of dying. So what do we do for the remaining patients? See, we're not able to give the medication for everybody. There are a lot of limitations. So it is estimated that only 10 to 12% of the people who have stroke, out of 100, only 10 to 12 people are eligible to receive this medication. Remaining everybody, they'll have either contraindication or they present out of the time window, that 4.5 hours time period. So we can give it. In those conditions, because of the technology, because of the inventions of the new modern age medicine, there is an intervention we can actually do to reestablish the flow. What we can do is we can go in either with a catheter. Catheter enters into the body through the groin, enters the blood vessel. Through the blood vessel, it come up. We go to the neck, go to the clot, another small catheter comes in, go to the clot. Either you suck the clot out with a suction, mechanical suction, or you lay a net kind of a device. Actually, these are the stents which are connected to a wire. You deploy that net kind of a device, and that net will capture the clot, and then you pull out that clot. This is the invention. This is the game-changing technology in the treatment of the stroke or the management of the stroke. And this can be done as long as, which if you remember the slide which I showed you, the penumbra is there, right? There are certain techniques of CT scan we can do, which will tell you how much of the tissue is already dead, how much is still at risk. So if you have enough tissue at risk, even after 24 hours or 48 hours, you can still go in and pull the clot out or suck the clot out. I'm going to show you a video of how this technique works. These are the blood vessels going to the brain. So this is a cut open section. A catheter came up. Another small wire goes into the brain. And when you inject it, we have seen the clot and we have seen the obstruction of the flow. This guide wire, which is like a less than 0.5 millimeter in diameter, goes through the clot. Then a small catheter guides over that guide wire, and then the guide wire is removed. These blood vessels are 2 to 3 millimeters or 4 millimeters in size. These are like looking bigger, but they are not. They are very small blood vessels. Now the stent kind of a device, as I was saying, the net kind of a device or a stent kind of a device or a stent on a stick comes, and you unsheath that thing. As you see, the blood already started flowing, and this net kind of a device is going to capture the clot, and then you pull it out. When you are pulling it out, you don't want small creases to break loose and go up. So you inflate the balloon and arrest the flow. You prevent the blood flow from going up. And then while you are pulling up, you hook this catheter, that blue catheter, to a suction pump. So you are actually sucking the blood out from that catheter while you are pulling the stick. So that's how the blood vessel is opened up. And this is a case which I have done. See how the blood vessel is blocked off on your left side. And this is after the procedure, how much blood flow has been blocked off by that clot. And this patient, like, back to normal, is one of the best cases. And this is about the ischemic stroke. So then the other type is the hemorrhagic stroke, the rupture of a blood vessel, or rupture of an aneurysm, or rupture of an AVM. I'll tell you a little bit about the aneurysms. Aneurysms are like outpouchings or ballooning out of the blood vessel. This is the blood vessel coming up like this, and the outer layer is not very thick. The blood vessel is holding the blood pressure with multiple layers of a tissue, and the very outer layer is very, very thin. It's like an onion skin-like, and it is like a balloon. So when the blood starts sometimes pounding through the layers of the the tissue, then the outer layer is not going to hold the pressure. So it starts ballooning out like a balloon, right? Balloons, where initially it is tough to blow, right? Once it starts growing, it becomes easier and easier, and it becomes bigger for the same pressure. When that happens, the aneurysm can pop. I think the Shravani slide, your desktop has vanished.
Okay, just give me 1 second.
Yeah. So the aneurysms can pop and cause what is the worst type of a bleed. It's a stroke, worst type of a stroke, called a subarachnoid hemorrhage. the reason why I say subarachnoid hemorrhage is the worst type of a bleed is, or a stroke is, the people who have this, 52% of them, they die before they leave the hospital, meaning only 48%. 48 out of 100, they make it out of the hospital. Remaining 52, they die either before making to the hospital or in the hospital. Can we get back the screen, Shravani?
Just give me a second. Vivek.
So while she's trying to bring the slides back on, I'll keep talking. So the subarachnoid hemorrhage, the symptoms of the subarachnoid hemorrhage are worst type of the headache. The worst type of a headache one can have. That is, you can go forward. Actually, we changed I started tracking. Yeah, right there. And then the people will have a neck stiffness or the severe pain, severe headache, change in the mentation, meaning unconsciousness, not able to respond, all these type of things. But the worst headache of the life is a clinching point for this type of a bleed. When someone has that, it is a bleed, not ischemic stroke. People have to be careful. So what can be done for that? You can go forward. So these are some numbers. Many of them have the aneurysms, but not everybody who has aneurysm is going to rupture, because the balloon is not going to pop unless it becomes big enough. So same thing here, aneurysm is not going to burst unless it becomes big enough. You can go forward. So what do we do for this? This is the aneurysm, what you are seeing, and there are various techniques by which we can fix this aneurysm, prevent the aneurysm from rupturing. So this is called a traditional old technique of a clipping. So what we do is cut open the skull, go in, pry open the brain, separate the brain lobes and go to the aneurysm and put a clip. It's like a, clipping off. So you can see the clip, you can see that outpouching the balloon or the bulb, which is nothing but the aneurysm. That's an ancient technique. And now the second technique is the advanced, which is a coiling, which is interventional. So the catheter comes like how it came before, through the groin, come up, and then another small catheter comes in, and then we'll put in a platinum metal coil. So it's a platinum metal which like forms a metal ball within the aneurysm and seals off the aneurysm. And then the blood layer will form right at the neck of the aneurysm, where the aneurysm is originating. That's where the blood layer forms on top of the clot, and it is eliminated from the circulation. The latest techniques, this is one of the examples of how we did it. So one of my patient, you see the bulb right there on the left, and what you see on the right is the coil mass, like excluding the aneurysm from the blood. The latest technique is a pipeline technique, which is nothing but, we know that, right? When you blow up the aneurysm, it keeps blowing, but when you stop blowing, it diffuses, meaning becomes shrink. So the same technique, as long as the blood is hitting into the aneurysm is getting bigger. Once you reduce the blood flow into the aneurysm, it's going to deflate, decrease in size, and go away. What we are seeing here is the pipeline, which is a thick stent, which is laid across the aneurysm, neck of the aneurysm, decreases the flow over a period of a time. This is what is going to happen. The aneurysm is going to disappear from the circulation. So the next slide is going to show one of the cases which I did. So you see the huge aneurysm, and in normal situations, it's very, very, very difficult to treat. But with the invention of these new techniques, we deployed a pipeline, within a pipeline, and this is a 6 months angiogram on the right side, which shows the aneurysm is completely gone and the blood vessel looks like a brand new. There is another new techniques available, but for the sake of time, I'll stop here and take any questions.
Yes, we will pick up some questions from the audience. Thank you so much for that insightful discussion, Dr. Bharat. Before we get on to the audience question, there was an interesting question here on the chat box. I think it's a medical professional who was asking that. Now, we all know there is an increase in the incidence of strokes. Almost 100% in India is the rise that we've seen in terms of statistics. Now, when we talk about mortality rate, comparative to the urban and semi-urban areas, because of the obvious reasons, the mortality rate in rural areas is quite high, extremely high. Now, we discussed about thrombolytic therapy and how it's important to reach the center, but in a country like ours, we don't have enough facilities available where that is done, or enough people trained to do that. I know this is a question for policymakers and not for a discussion today, but my friend is asking, what do we do in such situation? If there is a patient where we know that, there is a stroke and, there's no center close by, what do you have to say to them? This is an address to a medical professional.
So I can take that. So this can be answered in two different ways. So there are multiple ways in which you can address this. Number one, if you don't have a facility that is nearby that can handle a stroke, which in the US it would be designated as a primary stroke center or a comprehensive stroke center. Unless you have such a facility, what typically happens in the developed world, which can easily be mimicked over there, is that we have something called telestroke. So what happens with telestroke is that you have, for lack of a better term, a device that can do FaceTime or video chat. So the centers that are in the outskirts that don't have a stroke doctor or a neurologist will basically have a tie-up with another hospital that does have such a facility. And there will be a computer with a webcam on it that you bring on, and that has, they can examine the patient. They can basically pull up the CT scan if a CT scan can be done. They can pull up the CT scan and they can take a look at the images. And the doctors on the other end of the video at the stroke center can say, okay, this person is a candidate for the IBTPA or not a candidate for IBTPA. If they determine that the patient is a candidate for IBTPA, what they do is they give the doctor at the local hospital gives the IBTPA, which takes about 1 hour to complete. And then there's two ways in which it is done. One is called the drip and ship paradigm, where basically they give the IBTPA, and while the IBTPA is going, they transport the patient to another facility. But it requires a lot of infrastructure, because you have to have paramedics who are trained to figure out if there's a bleeding, if there's a complication, how to handle it, and stuff like that. More likely than that, it's going to be a situation where you finish the IBTPA and then you transport the patient to see whether the patient would be a candidate for something like what Dr. Naravitla was talking about with the stents or the stent retriever devices, the mechanical thrombectomy devices, which is basically where you go in, break up the blood clot, and open up the blood vessel. Until a couple of years ago, the time window for most of those mechanical thrombectomies were about 6 hours, but now it's gone up to 24 hours if you have a scan that is amenable to it. So, but even though you say that your time window is 4.5 hours, 3 hours in some cases, 4.5 hours in a smaller subset of cases for the clot busting medication, and 6 hours ideally or less for the stents to be used to pull the clot out, or even some cases up to 24 hours. The key there is to basically get it done as soon as possible and not say, oh, I got another 2 hours to get out of the window, so I have time. So in a situation like this in India, perhaps where you have a lot of hospitals in the periphery where you don't have a trained doctor who can give IBTPA or make the decision to give IBTPA, the best thing to do would be to meet with the local authorities and the public health officials and the paramedics and the transport companies that can help transport patients, and then come up with a workflow plan that can basically tap into the resources of a larger hospital and bring it virtually into this hospital by using telestroke. And then for those select cases that are candidates for mechanical thrombectomy or the stenting and that sort of stuff, the stent retriever devices rather, ship them out. to the facility where they can do that. This is going to really save lives, and this is very much employed even in the most developed nations. So if you look at the United States, not all hospitals are stroke centers. Not all hospitals have neurology coverage. So telestroke is very, very widely used. And it doesn't stop there. There's also something called tele-ICU or EICU. So if a patient has been given TPA at the local hospital and it is determined that they're not a candidate for mechanical thrombectomy, then there's no urgency to ship them out to a facility where they can do the mechanical thrombectomy. However, you can basically, they need to be observed in the ICU for at least 24 hours after they're given IV TPA, and for the first hour, you got to check the blood pressure every 15 minutes, then you got to do it every half an hour for 6 hours, and then every hour for the next 16 hours. And they have to get neurological checks every 1 hour. So that can only be done in an ICU setting. You cannot put them in a regular ward floor, a regular bed, and just forget that, about that whole thing. So, but sometimes the hospitals don't have the ICU coverage or critical care doctors to cover, or the pulmonology critical care doctors who can cover the ICU. In those situations, you can bring in a virtual doctor again using the same technology, which is called an EICU or tele-ICU technology. So virtual medicine would be an easy bridge for a situation like this, as long as A, there can be an infrastructure to help it, B, mobile internet connection. We should not depend on a dial-up or a landline or a cable, which is very dependent on weather. You should have a mobile, and with the new 5G connections coming in everywhere in the next 2 years or 3 years, the bandwidth on those is anywhere between 2 to 3 gigabits per second, which is faster than any landline internet, which means that you should be able to get HD quality images and scans and everything over in just under a second. So, and India has pretty good network coverage in almost all places with cell phone networks. So
but it's a very, very pertinent question, Shravani, actually, because if you look at it, like Dr. Anil mentioned, not every hospital in the developed world has a neurologist, and a lot of hospitals depend on tele-neurology, like he mentioned. And good thing that we are in that field, Click2Clinic, right? Before pre-COVID, telemedicine actually was not legal. There were no guidelines, and the government did not give a legal, there was a legal barrier before. But post-COVID, one of the things that has changed in the healthcare sector is that's one thing, it has been legalized now. There are published guidelines now, and a Click2Clinic empaneled, specialized neurologist who can take care of acute strokes, sitting somewhere, Mumbai, Delhi, Hyderabad, doesn't matter, can be taking care of 20 to 30 hospitals and be managing acute strokes, provided these hospitals have a determination to deliver the service, have protocols in place. If somebody is guiding the therapy, local staff has to be trained for that. So things like that. So it doesn't require a huge lot of resources. Like you said, it's also a decision or a plan that has to be, implemented by the decision makers, up high in the government levels and all. But it doesn't take a huge lot of resources. But when it comes to interventional strategies, like Dr. Bharat mentioned, that is something that has some bottleneck wherein you need to have some specialized equipment, specialized cath labs, specialized staff, well-trained in doing them. So you don't need to be having those specialized centers everywhere, like wheel in a spoke model. One particular center can be catering to multiple stroke centers everywhere. So
yeah, because we're running short of time, I don't want to miss out on one key discussion point. Definitely we have to talk when we're talking about stroke. So for yeah,
I'm sorry to interject, but I wanted to add one thing on this question.
Go on.
So at the setup like India, whoever that person, doctor who was asking that question is, what do you do when such a facilities are not available? So the first things first is, like, if you have this BFAST acronym is used, and you determine that someone is having a stroke. And once you don't have a headache, the 99% of that stroke is ischemic stroke. So in that case, what I would do is I would give some aspirin. It's a fundamental thing. Give some aspirin, let the blood pressure run high, because there is a lack of blood flow. So you keep the blood pressure high, don't bring the blood pressure down. People have a tendency in a rural hospital, when they see like high blood pressure, immediately give some medication, low pressure or something, and bring the blood pressure down. Should not be done. Let the blood pressure ride high and do what is next is required, like, TPA, telemedicine, thrombectomy, whatnot. But aspirin is the key. Even if it is like, you don't know whether it is ischemic stroke or a blood clot or the bleeding, still you are 87% likely that you are going to be right, because 87% of the times it is a blood clot, it is ischemic stroke, not the hemorrhagic stroke. So aspirin is the key. Unless there is a headache, keep the blood pressure up, give some IV fluids through the IV, and take him to the next hospital where the IV TPA can be, thrombolytics can be given, or mechanical thrombectomy can be done.
Sure. Thanks, Dr. Bharat, for that. Now, we cannot close a session on stroke without talking about the importance of rehabilitation and recovery post the acute phase, and what is the importance of it in the recovery for a patient. Can we talk about the role of rehabilitation in stroke management? Either of you can pitch in, please.
Yeah, so rehab after stroke is extremely important, and that's for several reasons. Because as Dr. Bharat said when he showed the slides, you can see that for every stroke there's a core that is lost, and there's an ischemic penumbra where the tissue is not getting enough oxygen, but there is enough oxygen there that it is alive, and that can be salvaged. Now, some of those tissues will actually be able to rewire, if you will, the part of the brain that is gone. And so oftentimes you can see that rehabilitation will cause or induce that rewiring. And if you look at the molecular markers inside the brain, which is basically the chemicals that are released that helps the brain rewire, some of these markers actually improve the sprouting of new axons, which helps the nerves connect each other. And the ideal timing of when a rehabilitation should begin is up in the air. The reason I say that is because there are studies that have shown if you do extremely intense rehabilitation within the first 10 or 14 days, that may be detrimental, because you're actually asking the part of the brain that has less oxygen now to work more to basically improve, to do activities, which can actually cause a worse prognosis in terms of the disability. So some studies have shown that actually early intense rehabilitation may not be the way to go, but waiting about do early, moderate or mild level rehabilitation, followed by about 4 to 6 weeks later, start the intense rehabilitation, because in the chronic phase or subacute or chronic phase of a stroke, intense rehabilitation hands down helps people recover. Now, there are several techniques, newer and upcoming techniques that are involved. One is transcranial magnetic stimulation, where they put a magnet and stimulate the nerve cells to grow or rewire. Number two, constraint technique, where they basically ask, if the left arm is involved, they put the right arm in a sling, or they put the right arm in a restraint and force you to use the bad arm so that basically the brain would rewire. That's the physical therapy aspect of it. Then there's also mirror image therapy and stem cells. That's a couple of studies have shown that it helps. Now, the other aspect of therapy is occupational therapy and speech therapy. So these can be, there's enough evidence that if this is started early on, it makes a big difference in the outcome in terms of A, quality of life, B, behavioral changes, and C, the way they are able to navigate the world with the disabilities that have. Physical therapy, when they're able to start after the immediate acute phase, followed by intense physical therapy once they're in the subacute to chronic phase. And if you do that, most people see that the recovery, the motor recovery is usually very fast in the first 1 month to 3 months. After that, the recovery slows down, and then, but there is still the potential for recovery more than a year out after a stroke. And that would require high intensity physical therapy, defined as 300 hours plus of physical therapy, 6 hours a day, 5 days a week for 30 weeks. So that's a pretty intense physical therapy if you think about it. So, but that kind of therapy should not be done in the first week or 2 weeks because that can be detrimental.
Sure. Dr. Bharat, all right.
I'm sorry, I couldn't hear.
Anything you want to add about the role of rehabilitation or physical therapy post-stroke?
I mean, as Anil was mentioning, it is very, very important, and it makes a huge difference in patient outcome, no matter how good we do the thrombectomies and acute care, but still the rehab is the key. And I want the people to understand that the recovery can happen up to 90 days. So don't lose hope on day 5, day 10, day 15. Things can still improve up to 90 days, and anything happen after that is still a bonus.
That's exactly where my question was coming from while we were collecting some survey questions for the session today. One thing that came up repeatedly is that, they've expected the recovery to be immediate or within the initial few weeks, but when they didn't see that, and you know how it is, I'm sure you would agree, and Sujit, you're open to comment on this. In a country like ours, patient compliance and the family's compliance to continue the therapy, sustain it, as advised for weeks and sometimes months, is the real challenge. Like Dr. Bharat rightly said, even after the correct treatment protocol that's been followed in the acute management of it, a lot of times there's no compliance in the follow-up with the rehabilitation. Would you like to add your comments there, Sujit? We'll close after this.
Yeah, so a lot of times, I have my own family members, with prior strokes, and 3 years, 4 years into it, they still get some physical therapists here and there to assist them, and then the range of motion, keeping the range of motion intact. Whatever the benefit that you gain by acute rehab, you have to maintain that. So there is a chronic phase to that in the rehabilitation. And then a lot of people have a misconception that, in order to do that, you need to have a physiotherapist all the time. No, that's not true, actually. Whatever they train you in the initial phase, you can keep them as your guide for the future. And then keeping up at that is the key thing in keeping whatever keeping whatever gains you have had in the acute stroke management. So,
sure.
So there's a lot that a patient that can do at home, beyond the stroke to keep up their potential.
Right. Thanks,
And Shavani,
yeah.
And Shavani, one thing that you brought up is really important. I want the viewers to understand this really well, which Bharat touched upon. If you look at all the studies that looked at giving IV TPA for breaking up the blood clot or removing the blood clot by using a stent retriever device, mechanical thrombectomy, all these things, if you look at the outcomes were looked at least 90 days after the intervention was given. So if somebody gets IV TPA, you see absolutely no change in them in the next 1 or 2 or 3 weeks. It does not mean that the IV TPA has failed, because you have still salvaged a large chunk of the brain that would have gone otherwise, that is now available to be rewired during rehab. And so eventually you are playing with a fuller deck of cards than you would have had you not gotten that treatment. That is extremely critical to understand, and it's extremely important, if there's any physicians here, to communicate to your patients when they get the IV TPA that, hey, we're not doing this for the most immediate recovery now. You'll see the effects of this down the line, 3 months from now, 6 months from now, 1 year from now, where you would be much better off getting this treatment now than letting this ride and losing that whole part of the brain that could have been recovered and then ending up in a worse situation down the line.
Right. Right. Yes.
Right.
Yeah, I was just saying that, I think we've discussed, apart from, all the insights and details that both of you have presented, I think the commonmost myths that most of the audience have had, and we've seen in the survey as well, has been answered. So stroke and you, the session today, this is for the audience. So the conclusion is, all of us can get it, any of us can get it, but most of them are preventable. We've discussed the risks, we've discussed the prevention strategies. Treatment is definitely possible. We've discussed the treatment modalities, and there is hope with rehabilitation post the acute management, and that's the last topic we've covered. So we hope the session was insightful enough for you and we were able to answer most of your queries. If any of the audience still has to follow up with questions or queries about anything that we discussed today, please do so on our social handles, either on Facebook or LinkedIn, or reach out to us on our website. We'll be happy to get back to you. My special thanks to both Dr. Anil and Dr. Bharat. Thank you so much for taking your time and sharing your insights with the audience at Click2Clinic. Thank you so much. Sujit, thank you so much for joining.
Catch
up on another interesting care session in the future. Thank you. And
just a passing line, an ounce of prevention is worth more than a pound of cure, especially in this setting of stroke.
Okay, yes. So prevention is the key. Prevention it is. All right. Thank you so much. You have a good day and a good evening to the audience. Bye-bye.
Thank you,
for
Shravan.
the panelists for joining. Thank you, Shravan.